So welcome, Dr. Roshini. Please join me to welcome her.
To start off with, thank you for that introduction and thank you for inviting me to deliver this presentation. Thank you, Minister Lucy, for that talk just now. A lot of what I will cover was covered, and that's encouraging to hear that we are on the same page on many aspects, so thank you. In this presentation, I will focus on the diversity of identities and experiences and how this is reflected in the mental well-being of Asians in New Zealand. I will also touch on how an intersectional approach perhaps to the health response can help meet these diverse needs. To improve population level outcomes will require effort, collaboration, resourcing, and policy attention. And I hope we have genuine commitment here today to see this through. As Tawiwi, we also recognize the substantial needs of Tangata Whenua. And when we speak of resourcing or policy support, we want it to benefit all, including Maori, and importantly, without reducing their share. As we have heard, Asians make up over 17% of New Zealand's population now, and this number is set to grow to 24% by 2043. Most Asians are of working age and fill gaps in workforce skills. Asians contribute significantly to New Zealand's social, economic, and intellectual growth, but unfortunately remain largely invisible and underserved by systems, structures, and policy. To begin with, the use of the term Asian in itself is problematic. It is not a single ethnic category. 12 years ago, I migrated to New Zealand from Sri Lanka, and since then have acquired a new ethnic identity of being Asian. I was not of Asian ethnicity before. Asians in New Zealand are highly heterogeneous in countries of origin, ethnicity, cultures, religious affiliations, languages spoken, and their social and economic positions. There are, however, threads of commonality between us. Asians are deeply linked to their cultural values and beliefs, and are from collectivist cultures. Many have distinct gender roles and a recognition of hierarchical orderings of relationships. Educational achievement, diligence, and perseverance are highly valued. This lends itself to the pressure on the community to uphold the perceptions of Asians being successful, accomplished, and resilient to external stressors. These pressures lead to the adverse mental health consequences, which are often hidden as the stereotypes also act as a barrier to accessing mental health support. The diversity of Asians also extends to their migration journeys, including visa status in New Zealand, and the varied pre-migration experiences. While some Asians may be rich, financial stress and job insecurities are also significantly high in the community. Experiences of family violence is high for some groups, particularly problematic for women who are financially and legally dependent on their spouses in New Zealand. Asians also tend to have multiplicity of issues occurring at the same time. For example, financial stress, addictions, chronic health conditions, and depression can co-occur. We are also diverse based on gender, sex, ethnicity, and so on. And I hope you get the picture. We are a mixed bag of all that is good, but also have had different forms of challenging experiences with impacts on our mental well-being. In Thriving at Crossroads, we explored lived experiences of ethnic youth in New Zealand and how it impacts on their mental well-being. In the early phase of the study, we examined how mainstream media referred to, viewed, or portrayed Asian youth. The overarching narrative mostly centered around success stories and how Asians embracing New Zealand's spirit of generosity can succeed. The current media discourse in New Zealand legitimizes the impression of a diverse and inclusive country with a generous spirit and filled with opportunities. However, under the shadow of these stories, the voices and struggles of Asians remain hidden. Asian young people speak of a hierarchy of identities in New Zealand. Their visible ethnicity is the single biggest marginalizing factor within the wider New Zealand context. They speak about needing to mold themselves into mainstream New Zealand society, conscious of skin color, hair texture, accents, food habits, or other socio-cultural practices. But they speak of a protective effect of being in New Zealand in relation to their additional minority identities based on gender or sexuality, etc. The wider New Zealand context affording them an opportunity to be who they are. Within the Asian community, however, they are marginalized by their additional minority identities. This often holds them back from living their best lives. Asian young people speak of having to navigate complex dynamics of acceptance and risks as they move in and out of various environments and communities in New Zealand. Amidst these lived realities, they strive to maintain a balance between being comfortable with their own identities and finding their trusted circles and the spaces they belong. Findings from our Youth 2000 Secondary School Survey indicate a significant proportion of Asian young people don't feel like they belong in New Zealand. The lack of connectedness and belonging in multiple spaces impacts on Asian young people's mental health and leads to low engagement and trust in existing health and community services. Among Asians, mental health is an issue, particularly for the groups shown here. However, barriers in data and research means that there are significant evidence gaps. Additionally, mental health stigma is a significant issue for the Asian community. As noted previously, almost all Asians have expressions of stigma surrounding mental illness, according to the 2021 survey by Asian Family Services. The absence of data and mental health stigma means the problem may be much bigger than we realize. The figure on the right from the Youth 19 survey indicates change in key mental health indicators from 2012 to 2019 among secondary school students in New Zealand. The black inner circle indicates no change from 2012. The red bars indicate the change for Asian students. And as you can see, the percentage increase for Asian students for significant depressive symptoms is particularly high. And this is not just about feeling low, it is about having significant symptoms that would usually have required referrals for clinical assessment and perhaps treatment. Asians also had highest percentage increases for periods of low mood and thoughts of suicide. Podium positions we really do not want to see. The situation is likely to be much worse post-COVID. Despite the evidence of significant need, service use data indicates Asians are least likely to be seen by the health system in New Zealand. Latest Ministry of Health data shows just 10% of users of the integrated primary mental health and addiction services and 2% of youth services are Asian. The graph on the right shows rates seen by secondary mental health and addiction services, again, lowest rates for Asian. In 2019, 1 in 5 Asian secondary school students were unable to access health care when needed. Of those accessing health care, since 2007, only a third or so reported receiving private and confidential care. 1 in 5 health service users reported being treated unfairly by a health professional due to their ethnicity. Youth 19 findings and other studies report high levels of racism experienced by Asian young people. These experiences in turn are associated with negative mental health measures, lower well-being, higher unmet health needs, and feelings of not belonging in New Zealand. It is critical, therefore, that any approach to improve Asian mental health must include interventions that address social and systemic racism faced by the Asian communities in New Zealand. Asians find New Zealand's health system to be complex to navigate and not inclusive. Some reasons for this are summarized on this slide based on research findings amongst Asian youth and Asian women in New Zealand. Even if New Zealand meets its mental health targets such as faster access to specialist care or primary care services, with very low health service engagement due to lack of trust in the system, it is likely that many Asians with mental health needs will not be reflected in the statistics. And the rates of mental health illness in this group will continue to climb. An intersectional lens offers us a way forward in responding to the diverse needs of Asians in New Zealand. One way of depicting the concept is shown by this figure indicating some selected examples of identities. Individuals may identify across multiple axes of identities and at any point on a given axis. For example, being female, a migrant, and a Buddhist will place me at opposing points to a male, a non-migrant, and a Christian. Intersectionality helps us capture different systems of domination, including the privileges that accompany gender, race, ethnicity, socioeconomic class, religion, ability, sexual orientation, and so forth. Intersectionality, because of the way societies and systems are structured, the identities below the domination line experience disadvantage even within those from a single ethnic group. Privilege and marginality, however, exist simultaneously. I may have privileges in being an adult and having tertiary qualification, but I experience marginality being visibly ethnic and being a female. Evidence from New Zealand and globally indicate that mental disorders are greater for population groups that are represented below the domination line, even within the Asian community in New Zealand. We also know that it is these very same groups that experience high levels of structural discrimination and unmet health needs. Health responses, on the other hand, largely favor those individuals and populations above the line of domination and assumes that a one-size-fits-all approach will work for everyone. In planning for a mental health response, be it in prevention, practice, or policy, we must remember that variations in privilege and marginality also exist within the Asian community. It is well known that the more socially disadvantaged groups tend to have worse health and tend to receive less health care and lower quality health care than the socially privileged. The inverse care law describes how people who most need health care are least likely to receive it. Experiences of household and neighborhood poverty among secondary school students in New Zealand are shown here. Columns are colored using a graduated scale with red representing the worst observed and green representing the best. We found racialized migrants, that is migrants of color, and Maori experience high levels of poverty at home and in their neighborhood compared to non-racialized migrants and Pākehā. And Maori experience the worst. When we look at health indicators and unmet healthcare needs, racialized migrants and Maori had poorer mental health outcomes, but higher levels of unmet health needs compared to non-racialized migrants and Pākehā. An example of inverse care law in action in New Zealand. Our latest analysis of the Youth 2000 data shows that among Asian students, those who have multiple marginalized identities, that is more than one marginalized identity, have the worst mental health outcomes. And some combination of identities appear to afford protection from mental health impacts, despite the presence of some degree of disadvantage. This approach analysis, still largely work in progress for us, provides an opportunity to identify vulnerabilities and resiliencies within the Asian community and can help to target health prevention. Overall, an intersectional approach to the health response can help create inclusive services for those who need it most, and will help foster a holistic approach to care that responds to the uniqueness, the complexities in identities, experiences, affiliations, strengths, and resiliencies within the Asian community. However, there is potential for success only if the conditions noted here can be met. And that includes true participatory approaches, high quality and relevant data, including research, partnerships and collaborations, including with expertise in the community, adequate resourcing and approaches reflected in policy. We can't treat our way out of the mental health crisis, and therefore must prioritize prevention efforts that address the underlying drivers of mental illness among Asians in New Zealand. Despite investment to expand clinical service, which is absolutely needed, the scale of the problem and the increasing trends means that the prevention gap must also be addressed concurrently if we are to improve outcomes at a population level. Yet up-to-date knowledge about effective prevention and how to embed this for the Asian community in New Zealand is acutely lacking. The lack of investment in Asian health research is reflected in vast evidence gaps despite strong and critical research expertise available amongst those with lived experience. A quick and brief exploration of research funded by the Health Research Council of New Zealand in the 10 years from 2011 showed about $2.5 million were awarded to research that primarily focused on Asians, a total of $2.5 million in 10 years. In each of those years, HRC dispersed something like 80 to 130 million every year. If we want to advance Asian mental health, we must see greater investment in Asian mental health research. The invisibility of Asians in other domains, as shown here, also needs to be addressed. In this light, it is critical also that New Zealand has an Asian health strategy. The request now sitting with Parliament's Health Select Committee. I hope that I have given you some food for thought and a reasonable backdrop for discussions that are to follow. Collectively, I have no doubt that we have the expertise and the commitment to improve mental health outcomes for all New Zealanders. We need to find ways to talk to each other, to work collaboratively, and have the wider structural conditions set right to move ahead. I sincerely hope today's deliberations will lay the foundation to meeting these goals. I look forward to the rest of today and wish the summit all success. Kia kaha, kia maya, kia manawani.